Wow. Hello.
Hello, Dr. Physics. Good evening.
Mrs. Adeyege. Hello.
Okay, everyone.
Hello. Yeah. Oh, the meeting is already being recorded, so I think we are starting.
Oh my God. Sorry.
Thank you
Yeah.
everyone for joining. I will just take off from now. If you all of a sudden cannot hear yourself, it's only because I've muted your camera or your microphone. So just bear with us for the short period of time we're going to spend here. Good evening once again. I'd like to welcome us to the first NCPS series of webinar that will be holding every other month going forward. And this is basically targeted as us looking for ways to improve our practice around the cardiopulmonary area of practice. And going forward, I am hoping that we'll be able to sustain the activities for this webinar series. And this will be looking at different areas of practice. Hopefully, within the next few weeks, we'll roll out the next events for us. I would want to recognize the presence of everyone here. If you're on this platform right now, you are an important person. So we will just go in the next few minutes and take off. But I wouldn't start this meeting without appreciating the chairperson of this association that gave it every push that is deserved for us to get to this point, Dr. Rita Arterial. Thank you very much for all the hard work behind the scene. And also to the secretary of the group, I'd like to also appreciate you, who concurrently holds sway as the first facilitator for this webinar series. So I'd like to appreciate you also. Without wasting much of our time, we will just hand over the microphone to the facilitator for the evening. We'll have Mr. Ben Omisore as the facilitator for the evening. We'll be looking at interpretation of arterial blood gases and its implication to physiotherapy practice. At this point, I would like to hand over the microphone to Mr. Ben Omisore. Thank you very much.
Good evening, everybody.
Good evening.
Thank you, Mr. Chigozie, for the introductions. You are well appreciated. I thank the NCPA for this opportunity to present on arterial blood gases. Those who know me personally know it's a favorite area of mine. That's why I chose it when Dr. Rita asked me to do the presentation, or when I chose to do the presentation. So I'm glad to be here. I'm glad to share my knowledge. I'm glad to learn from other people too, from my seniors here, even juniors, anybody who is coming with their own experience. For us to talk about this topic that could be a bit controversial, but very essential to our practice. So we take off now. There are many topics in cardiopulmonary physiotherapy, but ABG seems to be a gateway topic. I think somebody needs to be muted.
Yeah, I will do just that.
Okay.
Go ahead.
It's a gateway topic, like I said. By knowing ABG, you know many things in cardiopulmonary. Even if you are not working in critical care, it's a knowledge you should have. Even if you are just in a gym doing exercise prescription, it goes a long way to help you and to widen your thinking and your horizon while carrying out your practice. So I feel it's a field we should all know about. So I'll try to go to the next slide. It's not moving. Wow. Please, can you just see the introductory screen? Is it moving?
No, it's not. I think you need
it's not moving, no.
Wow. That's another thing.
I think you need to hit the button at your end.
You said?
I think you might need to hit the introductory button at your end.
Okay. What's the introductory button? Wow, no.
Mr. You need to open this. You need to open the slide on your laptop, and you click share.
Yes, I've clicked share. And
Have
said
you
you
opened it?
are,
Have
so
you
it's
opened
telling me
it?
you are
Did
screen
you open
sharing.
it? Did you open
Yes.
it on your laptop?
Yes, I opened it on my laptop, sir.
Okay.
He said you are screen sharing. Well, maybe I should take it off slideshow. Maybe it will move.
Yeah.
Oh, girl.
I think you should just stop screen sharing and then maybe try.
I should start all over again.
Yes, sir. You should start all over again, sir.
Okay. Oh my God, what's this? My God.
Are you able to share your screen now?
I close it. I'm opening it again now.
Okay.
Can you see this?
Yes, sir.
You can see the second screen. I think I can't use slide share, but is it still bold enough for some of you who are using your phones? I don't know.
Yes, yes. It's both enough.
Okay. So I plan to begin with these quotes by Robert Dimas and Stephen Harris. These are popular people in the world of laboratory and arterial blood gases. It says, of all the concepts employed in the diagnosis and treatment of respiratory disorders, few are more important or less well understood than those of blood gas interpretation. That's Robert. And Stephen says, in interpreting blood gas data, the creative therapist considers not only the present values, but attempt to understand what came before and predict what might come afterwards. So it's just telling us the value and the value and the importance of blood gas analysis. Let's look at this case study just to show why this knowledge is essential. This is a 25-year-old man with no significant medical history who presents to the emergency department with a 2-day history of fever, productive cough, and worsening breathlessness. On examination, he is hot and flushed with a temperature of 39.3. He does not appear distressed, but is using accessory muscles of respiration. There is diminished chest expansion on the left with dullness to percussion, bronchial breathing, and quas crackles in the left lower zone posteriorly. These are his values. The first 3 are his vital signs. The first 4, the pulse 104, respiratory rate 28, blood pressure 118/70, SaO2 on Rumia is 89%. So we have pH of 7.50, PaCO2 of 28.1, PaO2 of 57.8. What does this value tell you? How does it tell you to manage this patient? The values here they are telling you where to go. Not just that you use that and you listen to the chest and you're just, but it helps you to narrow your practice and your intervention for this patient. It helps you to narrow it into the right area where the patient needs to be treated. In this case now, this patient, he has 7.5 as pH, is an alkalosis. PaCO2 of 28.1 tells me that this patient is hyperventilating. If this value was presented to me without seeing the patient, I know this patient is hyperventilating because PaTO should be around 35 to 40. It's hyperventilating. PaO2 is 57.8. This is respiratory failure. This is moderate hypoxemia. Despite that the patient is hyperventilating, the PaO2 is still 57.8. On hyperventilation, PaO2 should be 130 millimeters of mercury. Should be very near that. But hyperventilating is having 57.8 millimeters of mercury. This value is telling me that this patient has problem with oxygen uptake, oxygenation problem. So most likely due to pneumonia from the history, the coarse crackles, the bronchial breathing, and all sorts are there. So those tell me that this patient needs, he is hyperventilating because of pneumonia. Number one, this patient needs oxygen therapy. And as a physiotherapist, because the blood is wasting in that area where he's having pneumonia, I will have to position in a way that gravity will assist me to shift that wasted blood to areas where it will go. But everything starts from looking at these values. So it's very important for us to know these values and understand them. Let's go to some definitions. Since blood gas analysis is a popular diagnosis tool, it's used to evaluate partial pressures of gases in blood. An arterial blood gas is taken from an artery. This blood sample is taken from an artery, either from the femoral artery or the brachial artery in the forearm or from the wrist. So it's used to check the pH, the PaO2. PaO2 is partial pressure of oxygen in arterial blood. PaCO2 is partial pressure of oxygen of carbon dioxide in arterial blood. So PaO2 provides information on the oxygenation status, while PaCO2 offers information on the ventilation status of the patient. So we have here, it says, when the patient is having hyperventilation, hyperventilation is increase in the rate and depth of respiration. Imagine somebody having a 100-meter dash. Throughout the time of running process, he is not able of moving air in and out of the lung as it should be if he walked that distance normally. So carbon dioxide builds up in the system. The body senses that. When the person stops that rate, it begins to hyperventilate. The rate and depth of breathing increases. And that person begins to bring out the CO2 that has built up in the system. So when then hypoventilation, maybe somebody did surgery, is having pain, he doesn't want to, because of the pain, is splitting the chest, is not breathing very well, it could be prone to CO2 retention. So CO2 will increase in the body. While other tests can be used to gain to know force oximetry and end-tidal carbon or carbon dioxide, ABG analysis is the gold standard in analyzing blood gases. It is the gold standard in analyzing blood gases. Typical APC. I think some people needs to be muted again. ABG, a typical ABG result will look like this: the pH, the PaCO2, the bicarb, and the partial pressure of oxygen. Then also the base excess. The base excess and the bicarb are the same thing. Where I work, bicarb is what is mostly used. Most texts that I see, bicarb is what is mostly used. That's why I'm going to use bicarb for this text alone. So here's a sample of blood taken for ABG analysis from a patient. So let me skip this. So when you see that a patient just has metabolic acidosis, that may not really help your treatment. You have to find out the nature of the acid-base disturbance and also the oxygenation status of the patient before concluding on the amount of the type of treatment to give the patient. So there's a systematic approach to interpretation. Let's look at this. There are 3 steps in this ABC. There's an ABC approach to ABG interpretation. Number 1 is acid-base status. B, basic primary problem. And C, compensation assessment. Doctor, please meet some of these people. They are disturbing this flow.
I will try and mute them. Just people that are muting them now. Go ahead, please.
Admin, can we please take it?
Yes?
Go ahead. I've muted everyone now. Go ahead.
So we are going to the A now, the acid-base status. So acid-base status is assessed by classifying the arterial pH. So what is the arterial pH? Arterial pH or pH is a negative log of hydrogen ion concentration. Look at this equation. CO2 goes into water to give carbonic acid. Carbonic acid goes to hydrolyze to give hydrogen ion and bicarb ion. So if somebody accumulates CO2 in the body, more CO2 will produce more carbonic acid. More carbonic acid will produce more hydrogen ions and more bicarb ions. And since pH is the negative log of hydrogen ion concentration, so the increase in negative hydrogen ion concentration is going to lower the pH and therefore increase the acidity. You understand? You reduce the pH, you increase acidity. So increasing acidity, decreasing pH is increasing acidity. Let's just put this equation on our mind. Let's just plaster it on our minds like that. Let's not forget, we are going to need it over and over again as we go on. So there are some clinical manifestations of derangement in acid-base bodies. So low arterial pH has a generalized depressive effect on the human nervous system. As the pH reduces, you see drowsiness, you see lethargy, you see coma, and ultimately death if it is not reversed. So a low pH, a pH that is around, let me say, nobody can survive below 6.8. And nobody can survive above 7.8 as well. You understand? So a pH of less than 7.8, it will not aid the survival of any patient. Then let me go and say a high blood pH has a general tendency to excite the central nervous system. So let's look at this chart, this picture. You look at where you have 7.4. That is the normal pH of the extracellular fluid. If you look at the top arrow, as they're going up, you find patient manifesting irritability, arrhythmias, convulsions, and ultimately death when you get to 7.0, 7.080. So when it comes down, look at the downward arrow, drowsiness, lethargy, coma, and death. So those are the clinical manifestations of abnormal pH of the body. So let's look at classification of pH. Normal pH is 7.35 to 7.45. 7.4 is the middle value, the central normal value. But when compensation occurs from derangement, from either alkalosis or alkalemia or acidosis, they fall between that 7.35 to 7.4 or 7.4 to 7.5. So that's the normal range of arterial blood pH. A pH of less than 7.5 is abnormal and it's called acidemia. So when you see a patient of having 7.3, lower than 7.35, you say the patient has acidemia or is acidemic. When it is greater than 7.45, you say the patient has alkalemia or alkalemic. You're just stating, you're talking about the state of the blood. When you say emia talks of blood. You understand? A condition that tends to now cause acidemia is called acidosis. Acidosis is the process or condition that causes acidemia. Alkalosis is a process or condition that causes alkalemia. You understand? So emia is the state, osis is the process or condition. So, like I said, normal pH is 7.35 to 7.45. Acidosis is less than 7.45. Alkalosis is greater than 7.45. So we are finished with the A now. We have moved to the B, basic primary acid-base disturbance. We want to look at the disturbances of acid-base balance in the body. So you classify them as either respiratory or metabolic. There are two organs that are in charge of maintaining acid-base balance of the body, two main organs, and that is the lungs and the kidney. The lungs excrete CO2. The kidneys maintain the metabolism of bicarb. You understand? The lungs are in charge of the CO2 removal and maintenance, and also the kidney has to do with the metabolism of bicarb. So what is called the primary acid-base disturbance? It is the root cause of the problem that led to the disruption. When you say this is the primary cause, sometimes the lung is the primary cause. In the case of that girl that we saw earlier on, it was the lung that caused the problem. That was what caused the primary pathology of the girl, the primary disturbance of the ABG. It was the lungs. That's why our case is a case of respiratory alkalosis. So you classify it based on that. Let's move on. So the adequacy of carbonic acid excretion can be assessed by simply evaluating the PaCO2. You can know how the body is quick to excrete carbonic acid. Like I said, when CO2 builds in the body, it goes into the blood and it gives carbonic acid. And carbonic acid increases to give H ions and so on and so forth. So a normal level of carbonic acid in the arterial blood corresponds to a PaCO2 level of 35 to 45 millimeters as shown below. When you have PaCO2 being 35 to 45, you can be sure that the level of carbonic acid in the arterial blood is normal. So the normal is 35 to 45. When it is greater than 45, you have respiratory acidosis. That is hypoventilation, CO2 retention. Respiratory alkalosis when it is less than 35. Let's just, should I say cram that or what? Let's just have that at the back of our mind as we go on. So when PaCO2 is higher than 45, you know it is respiratory acidosis. Lower than 35, respiratory alkalosis. So an increase in PaCO2 level is maybe called hypercarbia or hypercapnia. So the accumulation of acid in the blood is a measurable condition that tends to cause acidemia and therefore fits the criteria to be called respiratory acidosis. So let's respiratory alkalosis now. A below normal level of CO2 in the blood is called hypocarbia or hypocapnia. So when it is less than 35 millimeters of mercury, it is termed respiratory alkalosis. Like the case of that girl, the example that we saw, our PaCO2 level was 28.1. instead of being between 35 to 45. Ideally, should be 40. So, like I said, she was having respiratory alkalosis. So, please, let's pay attention here. There's an inverse relationship between PaCO2 and pH. If you remember the Anderson-Hasselbalch equation, sorry, I forgot to put that here. Anderson-Hasselbalch equation, but let me draw it in your mind. pH is equal to HCO3 over PaCO2. Let's just extract that from the Anderson-Hasselbalch equation. They call it the HH equation. So let's extract that from the Anderson-Hasselbalch equation. So there's an inverse relationship between the pH and PaCO2, and a direct relationship between the between the bicarb and pH. So if the change in pH is due to respiratory condition, the relationship between pH and PaCO2 must be inverse. There must be an inverse relationship for the change to be a respiratory condition. If it is not inverse, if it is direct, it is not the primary problem. You understand? From the explanation I gave, if PaCO2 mounts in the body, produces carbonic acid, produces more hydrogen ions, pH becomes reduced. You understand? And acidity increases. You understand? So that's just that about that. There's an inverse relationship between pH and PaCO2 for the condition to be called respiratory condition. So conversely, when PaCO2 is low, pH will tend to increase due to depletion of carbonic acid stores in the blood. Like that girl, let me go back to that example that was hyperventilating. Her PaCO2 was low. Carbonic acid store in the blood was depleted. And pH will rise. It becomes alkalosis. Because the cause was a respiratory, we call it respiratory alkalosis. But you can see from this, in these two scenarios, there's an inverse relationship between pH and PaCO2 before you can call it a respiratory condition. So let's look at metabolic acidosis. These are defined by exclusion. Any acid-based derangement that is non-respiratory in origin is called metabolic disturbance. So the value of bicarbonate in the blood is 24 plus minus 2 milli equivalent per liter. 24 is the central value, but it's a range of 22 to 26. So when bicarb falls below 22, it is metabolic acidosis. When it is greater than 26, it is metabolic alkalosis. At this point, just put this fact on your mind, just bring it on your mind. Any loss of bicarb is metabolic acidosis. Any loss of bicarb is metabolic acidosis. So let's move on. Okay, let's move on. I've already explained this. So I've already explained all this as well. So let's look at this. So like I said, there's a direct relationship between pH, that there must be a direct relationship between pH and bicarb for you to call it a metabolic problem. So unlike the inverse relationship between PaCO2 and pH, the relationship between bicarb and pH is direct. You understand? For example, a low bicarb of 18 milli equivalent per liter termed metabolic acidosis tends to cause a low pH. Likewise, an increased bicarb of about 30 milli equivalent per liter tends to cause an increase in pH. So as the pH, as the bicarb is going low, the pH is going low. As the bicarb is going high, the pH is going high. So a novice can see a value of 18 a mean equivalent per liter of bicarb and see the pH being 7.60. They want to say this is a respiratory problem. No, it is a metabolic problem. It is because there's an inverse relationship. There's a direct relationship if it is to be called a metabolic problem. So let's look at this diagram. So when PaCO2 is increased, pH drops. When PaCO2 decreases, pH increases. Bicarb increases, pH increases. Bicarb decreases, pH decreases. You can see the inverse and the direct relationship of these two components with pH. So identify acid-base disturbances. When all the values are normal, you call it a normal acid-base status. Let's look at this example. pH is 7.38, PaCO2 is 38, bicarb is 23. 7.38 is within normal limit, 38 is within normal limit. Remember, PaCO2 is 35 to 45, bicarb is 22 to 26. So this is a normal acid-base status. So let's look at this one. Example 2. You have pH at 7.28, PaCO2 at 37, bicarb at 17. How do you classify this? Can anybody try? This is a classical case of metabolic acidosis. Let's analyze. The OSIS is acidosis. When there is acidosis, it's either PaCO2 has increased above normal or bicarb has reduced. If you look at the PaCO2, it is within normal limits, 37. Bicarb is 17, it has dropped. And remember, I told you earlier that a drop in bicarb is always metabolic acidosis when you are considering it as a primary disorder. So this is metabolic acidosis. Once you see it, you can know what is causing the problem. It is not the lungs. Let's look at another example. The pH is 7.55 abnormal. PaCO2 is 25. Bicarb is 23. So let's analyze. pH is abnormal. It is 7.55. It is alkalotic. So it's on the alkalotic side. When there's alkalosis, it's either the PaCO2 has gone down, has reduced, or bicarb has gone up. You understand? When there's alkalosis, it's either PaCO2 has dropped or bicarb has increased. So what happened here? PaCO2 has dropped out of range. It has dropped from 40 to 25. It tallies with the pH. So this is called respiratory alkalosis. The problem is from the respiratory system. Another example, 7.10 is acidosis. For acidosis to take place, PaCO2 must have shot beyond range, beyond 45, or bicarb has dropped. So who wants to classify this? Can I get a feedback from the house?
You can answer on the
I think
chat.
this is mixed. This is both metabolic and respiratory, I think.
Thank you, Ma. Thank you, my chairperson. So this is a, there's the example again. So this is a mixed acidosis. You understand? Let's analyze it. The pH is acidosis. So for acidosis to occur, pH must have shot above range, which is what actually happened here, and bicarb must have reduced. Both are pulling the pH in the same direction. You understand? So there is nothing like compensation or anything here. So just say this is a mixed acidosis, or just a mixed respiratory and metabolic acidosis. So this is a mixed disorder. So example 5. Let's look at the pH. The pH is acidosis. Acidosis, PaCO2 must shoot above range or bicarb must have dropped. So here we have PaCO2 below range. So it is not responsible for this pH change because the PaCO2 did not move in the acidotic range. Bicarb, however, tallies because there's loss of bicarb from 24 to 17. So this is metabolic acidosis. Metabolic acidosis. You get it? When we consider compensation, we might come back to this very example. So compensation assessment is defined, compensation is defined as a return of an abnormal pH toward normal by the component that was not primarily affected. So by if it was the respiratory system that caused the problem, then metabolic, we try to compensate. If it was metabolic, it will be respiratory. Please, let's go to, in our mind, let's go to back to that Anderson and Steinbach equation again. pH is equal to bicarb over PaCO2. Let's assume now, I just want to change the value so that this will be very clear to us. Let's assume bicarb there is 14 and pH is, PaCO2 is 2. 14 divided by 2 is 7. That means pH is 7, like we have it in the chemistry lab. pH means 7. So if that 14, that bicarb now jumps to 21, to maintain the pH at 7, what will PaCO2 change to? Please, can I get a feedback?
3, sir.
3, thank you very much. So it must jump to 3. So if bicarb jumps to 35, PaCO2 must go to 5 for the pH to remain normal. So that's how compensation is done in the body. When PaCO2 reduces, bicarb must also reduce to maintain normal pH. When it increases, the other one must also increase. That's how compensation is done in the body. So for example, when an abnormal respiratory acidosis occurs, the body, that is especially the kidney, responds by developing a compensatory increase in blood base. You understand? There must be an increase. If one increases, the other increases, the other decreases, the other one must decrease as well. So one of the acid-base components is abnormal and the other is within the normal range, the abnormal condition is said to be uncompensated. One of the examples we saw was an uncompensated one. If one is out of range, but the other one is still within range, you call it uncompensated. Let's look at this. pH 7.2, it is acidosis. For PaCO2 tally, it must increase, and we see that it has increased here. Bicarb is 25. So what do you call this? This is uncompensated respiratory acidosis. But I've seen some authors, at least 2 authors now, that says that when you are considering compensation, you use the central value, which is 24, to assess compensation. Maybe we can chew that up when we are doing the discussions. But for now, this is uncompensated respiratory acidosis because one value has gone out of range, PaCO2 have gone out of range, bicarb is still within range. And the range of PaCO2 tallies with the pH. So this is uncompensated respiratory acidosis. Another case, what do we call this? This is an uncompensated metabolic alkalosis because bicarb increased, but PaCO2 is still within normal range. You see the pH at 7.1. This is alkalosis. For alkalosis to occur, PaCO2 must drop. So bicarb is the one that tallies. Those this metabolic alkalosis. But because PaCO2 is still within normal limit, we call it uncompensated metabolic alkalosis. Example 8, 7.6. So that is alkalosis. The value of PaCO2 tallies with the pH. There has been a decrease in PaCO2, and the bicarb has equally increased. Bicarb should decrease to compensate, should decrease from 24 to compensate, but there's no compensation here from this value. So you have a mixed respiratory and metabolic alkalosis. There's respiratory alkalosis, there's metabolic alkalosis. No compensation is occurring because both organs have issues. So let's deal with partially compensated as basic problem. When compensation is evident, but the pH remains outside the normal range, the primary acid-base disturbance is said to be partially compensated. So let's look at this. This is acidosis, the pH. The PaCO2 tallies with it. The bicarb does not tally. The bicarb has increased to compensate. But because the pH has not entered the normal range, you call it partially compensated respiratory acidosis. Partially compensated respiratory acidosis. Because the pH is yet to enter the normal range. The bicarb has also shot from the normal range. No, I told you for compensation to occur, when CO2 increases, bicarb also increases. CO2 increased from 45 to 68. This one increased from 24 to 32. But it is not yet enough. Maybe this is just the first day that this patient was brought to the hospital. There's been the kidney has been able to kick in, but not fully kick in to complete the compensation. So you can see this one as also alkalosis. PaCO2 tallies with it. Reduction in PaCO2 should be alkalosis. Reduction in bicarb should be acidosis. So bicarb is not the issue. This is a PaCO2 problem. You understand? But bicarb has reduced considerably to compensate, but the pH has not entered the normal range. So you call it partially compensated respiratory alkalosis. So another example on this is this. So it's partially, let me go to completely compensated acid-base problems. Now, this is 7.37. You have PaCO2 as 50, bicarb as 28. You understand? These are abnormal values. You understand? This patient was coming from the acidosis end for it to enter 7.37, since there is no overcompensation. And the bicarb is 28. So this is a completely compensated acid-base problem. These are abnormal values, but the pH is within normal range. you will see this kind of values with COPD patients. Abnormal PaCO2, abnormal bicarb, or normal pH. Their body is used to the compensation process. So let's take one or two more. So this also completely compensated respiratory acidosis, okay? It's the last example under this. So it's a compensated metabolic alkalosis. Bicarb caused the problem, but CO2 has written to the occasion to compensate. Now let's look at oxygenation status. Here, we want to look at the relationship between PaO2 and FiO2. We want to relate the two together. So let's look at PaO2 classification. Hyperoxemia is when you have partial pressure of oxygen greater than 100. And you only have it greater than 100 when somebody is hyperventilating or when they are under oxygen therapy. Hyperventilation can get the PaO2 to around 130 millimeters of mercury, but not beyond. But oxygen therapy can take it to 350, 400 as such. You have normoxemia, which is between 80 to 100. And we have mild hypoxemia, 60 to 79. Moderate hypoxemia, 45 to 59. When it is less than 45, it is severe hypoxemia. Now, let's look at the efficiency of oxygen uptake. Normal FiO2, PaO2 relationship. In normal individuals, the PaO2 value is approximately 4 to 5 times higher than the percentage of oxygen being inspired. Remember, the normal FiO2 is 20%. Normal FiO2 is 20% or 0.2. I want to take it in decibels. Thus, normal PaO2 in room air is 20% O2, is 80 to 100 millimeters of mercury. Here we said between 4 or 5 times. So 4 times 20, you have 80. 4 times 5 times 20, you have 100. That's why you have the range as 80 to 100. So for somebody getting oxygen therapy of 40%, you understand? So you have the range between 160 to 200. 4 times 40 is 160. 5 times 40 is 200. So you have it as their range between 160 to 200. So normal PaO2 on 70% is the same. You have it as 280 to 350. So if somebody is taking oxygen therapy and at 70%, the PaO2 is now 100. 100 is normal, but it should be more than 100. So you should know that that person has a respiratory dysfunction, has something to do with oxygen, has a problem that has to do with oxygen uptake. Even though the oxygen is there, the uptake is low, or the uptake is bad. You can use this FiO2, PaO2 relationship to know that. So let's look at oxygenation ratio. This is gotten by PaO2 to FiO2. You divide the PaO2 by the FiO2. So the normal oxygenation ratio is 5. 100 divided by 20, which is 5. The lower the oxygenation ratio, the less efficient oxygen uptake in the lung is. And the more severe is the pulmonary impairment. So when you have it between 4 and 5, it is normal. When you have 2 to 3.9, it is moderate pulmonary dysfunction. That girl that we saw in the case example had moderate pulmonary dysfunction. So if it is less than 2, that's substantial pulmonary dysfunction. So ABG and the work of physiotherapists. Risha et al. In 2023 found out that pulmonary function and arterial blood gas readings were enhanced through immediate chest physiotherapy among extubated extubated patient in the ICU. This is a common observation that we stick to here as well for open heart surgery patients. So the ABG report is imperative to the work of physiotherapists in the following ways. Helps you to evaluate oxygenation, know the PaO2 and the saturation level. It helps you to determine patient oxygenation status, which is critical for exercise and physical therapy, physical activity. You know if you should position the patient supine, prone, sideline, and all that. It helps you with that kind of a knowledge. It also helps you to monitor the patient respiratory function, particularly those with chronic respiratory diseases, such as chronic obstructive pulmonary disease or pneumonia. You need to monitor them and know their values. And you know that you don't, for COPD patient, you don't just want to say you want to just give them oxygen like that. You don't want to stop the hypoxic drive. So all this kind of monitoring will help you. And in pneumonia, it guides you on where to position the patient as well, when you know the acid-base status and the oxygenation status. So it helps you to guide the exercise intensity. You know the value, you know how to progress the patient. The ABG value tells you that if a patient is prone to retaining CO2, you don't want to exercise that patient at full intensity immediately. You want to take it in a stepwise fashion. Then it also helps you to evaluate acid-base imbalances while you are exercising the patient. Then it helps you to collaborate with healthcare teams. You collaborate with the nurses, the doctors, on how you want to treat a patient. When you know the ABG value, you want to turn the patient to a particular position, you'll be able to explain your rationale to them why you want to do that based on the data that you have. Then lastly, you can use it to monitor the patient progress. Serial ABG measurement enable physiotherapists to monitor patient progress, adjust same physiotherapy interventions as needed to optimize patient. So you may need to change your technique as ABG measurements come up, and as you see them, you interpret and you know what to do, which direction to go to progress the patient. And this is also good for research as well among physiotherapists worldwide. So you can see a picture of a patient gladly receiving physiotherapy care from a physiotherapist. And so in conclusion, I said, by considering ABG report findings, physiotherapists can create personalized treatment plans, optimizing patient care, and promoting effective rehabilitation outcomes. These are my references. Thank you for listening, and thank you. I hand over the mic back to Dr. Chigozie. Thank you very much.
Thank you very much. Thank you very much. I wish I could say a round of applause to you, but thank you very much for the time you've spent going through this with us. I found it quite useful, and I've had a couple of people send me messages on WhatsApp saying that this is quite rich. So thank you very much for your input this evening. On behalf of the platform, we'd love to appreciate you for time spent going through this with us. I'll be calling on those that have questions to drop their questions on the chat. There's a first one here. Can we get the slides? It was so much impactful. There's a question from someone asking for the slides. It will be down to the presenter whether to make this available or not, but I'm sure we'll get to that point. Thank you very much, Favor. And I will also put a message on the group on how you can join the NCPA officially if you wish to. After this meeting, you can either send myself a message on WhatsApp or also send the secretary a message just to show interest, and you will be added onto the group. Sadly, I cannot share the link here for some reason, So yeah, I would love to take any clinical question we have for the presenter this evening before we would. There are other comments coming through. This is a very rich and impactful lesson. Thank you very much to the facilitator and the coordinator. Thank you very much, Vincent. Thank you very much, Dorothy. And thank you very much, Vincent, also saying thank you very much, sir. I would like to also just remind us that whenever you get a referral saying for intensive chest physio, I don't know if people still get referrals like that in Nigerian teaching hospitals, but it used to be a thing.
Aggressive physiotherapy.
Aggressive chest physiotherapy. Don't go and beat the patient though. Essentially, there are lots of time when we're presented with patients that are retaining CO2, even though you haven't looked at the ABG most of the times, and you're forced to just go ahead and start performing manual techniques on the patient. Even as much as that may be helpful, what that patient needs is a bit of CO2 clearance, a bit of support to clear CO2, and not any form of aggression, basically. So we need to have a look at our ABGs to determine when a patient will need a CPAP, when a patient will need an NIV. Basically, having 2 to 4 hours of BiPAP will help many people to actually recover quickly, rather than going on and on trying to perform some miracle. So look out for when you have those type 1 respiratory failure and those type 2 respiratory failures, and advise yourself what needs to be done, whether we need to do a CPAP or we need to do BiPAP for our patients before we go on to the aggressive bits, please. Thank you very much again. I felt like I needed to mention that before the session ended.
Should we start demanding ABG? Hello? Hello?
Yes, go ahead. Go ahead, sir.
Should we start?
Sorry, I struggled to hear the last person who spoke. Can you repeat yourself, please?
It's really not clear. Coordinator, we can't hear. The person could just type the question.
Let the person just type the question.
We cannot hear. It's not clear. The question should be typed.
Okay.
Thank you.
So please, if you have any question, can you please type it on the chat so that we can all benefit from that? And I'm going to read out the first question we have on the group. Oh, sorry, I think I've lost 1 or 2. I don't know why this keeps refreshing. So suppose you're practicing in a remote area without the necessary up-to-date adjunctive laboratory facilities. What would the presenter suggest doing? What are the alternatives to ABG? That's basically what this is about.
There's a specialty of physiotherapy called community physiotherapy. But let me just say, since there's no laboratory enhancement or whatever that you can have, you have to use your experience for that kind of a patient and do what you can do to help that patient to sustain his life before you get him to a better treatment area if he needs that. You understand? By the time somebody in a remote area is needing to do an ABG, that person should be in the hospital. So whatever you're even going to do should be just to help the person maintain his life to hold on to life till they get to a place where they can have proper care. You understand? As you can employ your techniques of chest physiotherapy, positioning, mobilization as needed. Whatever is needed for the patient, just do it. Even when the doctor says aggressive chest physiotherapy, if you know that chest physiotherapy is what you're going to do, just correct the doctor, but go ahead to do what you have to do. Whatever you need to do for the patient, just do it. That's by the way. But if you're in a remote area, there's no laboratory enhancement, there's nothing, you just have to use your experience and improvise as much as possible with your manual techniques and patient-owned individual effort as well. That's all I can say from how I understand the question.
Thank you very much. I can vouch for what is happening with respect to ambulance services in different parts of Nigeria, but I think if we can get this patient to a tertiary institution where we have access to actual laboratory findings, that would be very helpful.
That is the best thing. And
we don't want to
I wanted to say in our institutions in Nigeria, can we start demanding ABG analysis, especially for those in critical care? They only do it in my center for open heart surgery patients. Too bad. For other patients, nil. I asked, they said because it's expensive, that it's already, the IC is already over 100,000 naira already. We had ABG to hit, how much will it be? And I sympathize with the patient as well. But I think with the frequency of use, the price will go down. Majorly, I'm just saying that if you can start talking about it, start asking for it. For those, especially those who are working in critical, let's keep demanding it. I need ABG results for managing this patient. Maybe that will help the doctors to wake up and do it for patients that can afford it. At least they can start with that. That's just a suggestion, sir.
Thank you for that feedback. I do appreciate it. Obviously, there's lots of navigation to do with that. And I am sure in the future, or provided we keep saying the right things, we will get it right at some point. And we can't also neglect the fact that the realities of the fact that 90% of Nigerians still pay out of their pocket for medical needs. It does affect how these kind of conversations go. But I do think if we keep saying it, we're going to get it right at some point. There is another question here about taking arterial blood is very painful. Is the ABG test done constantly for monitoring purposes? Do you want to answer that, Mr. Omishore, or should I go ahead?
What did he say? He said if the test is painful.
Yes.
Yes, they are going to withdraw blood from the patient. Most likely, the patient is on the bed, most likely unconscious, will be conscious as well. So they are going to insert a needle and they get a blood sample from the patient. So it will be slightly painful, but it's very necessary.
Also important to note.
Can I make a comment on that? Sorry.
Yes, ma'am.
Yes, go ahead.
You remember what we said was that it's usually taken from the arterial line.
Yeah. So it's
those times, these patients that have it, they need frequent monitoring. So arterial line is not what they just put in and bring out immediately. And why they leave it on is because they will need to keep taking the blood samples. So the painful part is just inserting the arterial line. Once it's there, anytime they are extracting the blood for the ABG, it's no longer painful. It does not hurt. That's my comment on that. Thank you.
And that's correct. Thank you so much, Chairperson. That's a correct response to that. The first bit is inserting the outline, but beyond that, it's no longer painful. What we're looking at is the ABG, not the VBG. So also important to note that there are places where you can find VBG results. Always make sure you discard the pressure of oxygen you get from a VBG. Pay attention to an ABG for pressure of oxygen rather than a VBG. It's quite important. Thank you. Wow. we're getting to the very end of this session. I'd like to thank everyone who has participated in this meeting. We had a total of 66 plus persons coming in for this series, and I know we can obviously do better the next time. I am hoping that the next time we'll have this meeting that we will be able to attend and make input where necessary. I would like to appreciate the presence of some of our colleagues that has joined us for this very series, and say a big thank you to the professors and the academics in our midst that has come round to support this series. Thank you very much. And also our big organs from the clinic whose presence obviously remain quite very useful to us in understanding some of the ways to navigate around our various tertiary hospitals. Thank you very much. And at this point, I would like to hand over the microphone to the chairperson of the NCPA, Dr. Rita Tivia, to make a closing remark for us. Thank you very much.
Thank you very much, our clinical coordinator, Mr. Uchewoke Chigozie. Thank you very, very much. I want to use this opportunity to thank our presenter, the facilitator of this first series, Mr. Omishore. We are really, really grateful. We wanted to start and we didn't want to waste time, and you took it upon yourself to start off this series. And it wasn't rushed. It was a very, very loaded one. We've had series of presentations on ABG, but you went even further. You got to the extent of telling us about oxygen therapy too, in addition. So we really, really appreciate this presentation. We appreciate this teaching, and we are sure it's not going to end this way. I want to encourage us, the participants, people that joined in, to register with this group, this association, the NCPA, Nigeria Cardiopulmonary Association. I want to encourage us to be part of it, because actually this webinar is supposed to be just for members, but at this stage we are still leaving it open to everyone. It will get to a level that it will not be restricted to members, but we don't want anybody to lose out. So we are encouraging us to be part of this association. We have a whole lot of things to do in Nigeria in the aspect of cardiopulmonary physiotherapy practice. And it is starting now. It is starting with these frequent teachings and webinars that we'll be having. If you note, at the end of this teaching, we already have something that we're going to work on. What we have is ABG frequency. How do we get it done in Nigeria often, knowing how important it is? So these are some of the things we'll have to come together and try as much as we can to make it happen. We want to improve our practice so that we can meet the global standard. And it's starting from now. Knowledge is power. We want to start improving our knowledge. And so we'll be having frequent webinars, and therefore encouraging members to join us. This is just part of what we'll be doing as members of NCPA. We'll still have researches. We have our research coordinator, and she will still be rolling out our plans too concerning that. So we are encouraging everybody to be on board as soon as possible. Again, I want to encourage members to submit topics to the coordinator. If you have something that you want to share with us, you can discuss with the coordinator. You can only do this as a member of NCPA, really. So if you join, then you can always speak with the coordinator for any presentation you want to do. He will go through the process and then we'll tell you what to do. Okay. I want to thank all of us. I don't want to take much of our time anymore for being a part of this. I will not fail to thank our parents in the profession, people that have stood for this cardiopulmonary group, that are always behind the scene working, people that are always there giving us the necessary advice we need. I can't mention everybody, but I will not fail to mention Professor Rufus Adedoyin, the pioneer chairman of this group, We want to say a very big thank you to you. You are still there. You still came in to join us on time. We want to thank Dr. Odunaya. We want to thank Dr. Jibril. I want to thank Dr. Aweto, amongst many of us, and the very young ones too that are always there, Mrs. Chioma Onuchuku, and the rest of us. We are grateful. Let's, like we have always wanted to do, come together and build the cardiorespiratory physio practice in Nigeria so that we can meet the global standard. Once again, I say thank you, everyone. Coordinator, am I closing this meeting?
Yes, I think you're free to do that, please. Thank you.
Okay, so we'll still put forward how to join in the different platforms for people that want to become a part of this group. I'll be having our next meeting next month, so we are all welcome. And before then, we'll get a list, like the coordinator has said, of the topics and the presenters that I'll be having in the nearest future. Once again, I say thank you to everyone, and I wish us all a good evening. Remain blessed. Bye.
Thank you very much. We would like to be exiting from the meeting now. I would come and have a quick conversation with some of us. Bye.